Yeah.
This makes it a little awkward. Okay, first we're going to talk about a patient case. A 29-year-old female with a history of Graves' disease started on methimazole 10 milligrams BID 2 months prior, who presented with somnolence, fatigue, fever for 2 days up to 105. She was tachycardic and leukopenic to 0.23. She was found to have agranulocytosis and methimazole was discontinued. The patient received propranolol in the ED, which resulted in hypotension from giving too much propranolol, and she was started on a norepi drip. She was also given hydrocortisone 25 milligrams IV Q8, lithium 300 milligrams Q8, and cholestyramine 4 grams QID. Eventually, pressors were weaned, and she received 2 units of platelets for agranulocytosis. She was converted to a euthyroid state and proceeded with total thyroidectomy. Her postoperative course was completely uncomplicated. Her TSH was low, and she was tolerating PO, and she was discharged home. So this is a picture from the surgery just for fun, but this was after we had mobilized the left lobe of the thyroid and after we had removed the thyroid completely. So going back to some of the general features of thyroid storm, it commonly occurs in patients who have a long-standing history of hyperthyroidism, and it's precipitated by an acute event such as infection, surgery, trauma, and an acute iodine load. Among these, infection is actually the most common inciting factor. Some of the common clinical features, you will see cardiovascular instability. They can have AFib, they can be tachycardic, they can have systolic hypertension and decreased peripheral vascular resistance. And they'll have hyperpyrexia with fever commonly between 104 and 106, altered mental status either ranging from agitation to florid delirium or in a coma. And they may have some GI dysfunction, but the clinical presentation can vary significantly. But fever is almost always present. The workup is, I'm just bringing this up, but it's pretty unremarkable in diagnosis. On labs, we might see a low TSH, elevated free T3, free T4, hyperglycemia, hypercalcemia from hemoconcentration, leukocytosis, and elevated LFTs. And all of these labs can be seen in patients with uncomplicated thyrotoxicosis. So they don't really help in diagnosing. And this also brings me to the Birch-Wartowski scoring system. It was developed in the early 1990s, and it uses very specific clinical criteria to identify patients in thyroid storm. So it'll use combinations of the degree of the fever, the heart rate, and a score below 25 makes thyroid storm very unlikely. A score of 25 to 44 is suggestive of impending storm, and a score greater than 44 is highly likely that you're in thyroid storm.
So like the weather?
Hmm?
The weather?
There were children.
So the main point so far is that thyroid storm is a clinical diagnosis, right? On labs, you'll see biochemical evidence of elevated thyroid hormone in the presence of life-threatening symptoms. So you have to take it into account both ways. But there are certain clinical tools that can help. And treatment is multimodal. It'll involve 4 main goals: blocking formation of new hormone, inhibiting the actions of hormones that have already been formed, supporting vital organ functions, and treating the precipitating event. And for treatment, supportive therapy involves your standard IV fluid resuscitation, nutritional support, antipyretics, cooling blankets. And of note with antipyretics, one mode of therapy is the thionamide, and it acts by inhibiting thyroid TPO. And the 2 main agents that are commonly used are PTU and methimazole. It blocks the synthesis of new thyroid hormone, and typically we give 600 milligrams as a loading dose and then 200 to 250 milligrams every 4 to 6 hours. Non-radioactive iodine is a more debatable mode of therapy. Some people like to use it, others don't. It inhibits the organic binding of thyroglobulin to iodide, and it prevents release of thyroid hormone into circulation. And there's also the Wolff-Chaikoff effect, where exogenous iodine can inhibit thyroid hormone release into circulation, but after a certain period of time, that effect wears off, and that excess iodine can actually be used up by the thyroid gland to produce much more thyroid hormone. So it's only effective for about a week. But if you do choose to administer it, then you would give SSKI, which is supersaturated potassium iodide, 5 drops PO every 6 hours, 1 hour after thionamides are administered. And both methimazole and PTU can cause common side effects like pruritus, rash, urticaria, arthralgias, fever, nausea, or vomiting. And mild skin reactions can commonly be treated with an antihistamine without stopping treatment. But if you are giving PTU and you notice a rash, then you might want to think about a vasculitis on your differential, a PTU-induced vasculitis. And to continue with treatments, beta blockers are also a mainstay of therapy. They're usually administered immediately when the patient presents to the ED. And beta blockers are not only effective in inhibiting the beta adrenergic stimulation, but they also prevent peripheral T4 to T3 conversion. So if the patient's hemodynamically stable, then you could give them 40 to 60 milligrams PO every 4 to 6 hours. If they are hemodynamically unstable, then you would resort to the IV form, 1 to 2 milligrams every 15 minutes, up to a max of 10 milligrams per day. Glucocorticoids have some role in therapy because they might suppress the underlying autoimmune response that's responsible for thyroid storm, and they also reduce T4 to T3 conversion. Hydrocortisone is the agent of choice with 100 milligrams IV every 8 hours. Bile acid sequestrants prevent the enterohepatic recycling of thyroid hormone. Cholestyramine.
Cholestyramine for Harry.
Immediately applicable.
Cholestyramine is given 4 grams PO 4 times a day. And if patients cannot tolerate thionamides, then lithium carbonate can be given. The mechanism isn't exactly known for lithium, but inhibits the release of thyroid hormone into circulation and can be given 300 milligrams PO every 8 hours. In the long term, with clinical improvement or improvement of the CNS or cardiovascular symptoms, the iodine can be discontinued and glucocorticoids can be tapered. And you withdraw beta blockers once thyroid function tests come back normal. And thionamides are titrated to maintain euthyroidism. And PTU is preferably switched to methimazole in the long term because it's more effective at maintaining a euthyroid state. Now, there are a few clinical scenarios in which you should consider alternatives to medical therapy, and that is if, as in our patient case, there's an adverse reaction to thionamides, if patients can't tolerate them, or if patients have any severe underlying cardiac or pulmonary disease that requires expedient resolution of symptoms, then you want to consider surgery. And you should, or if people aren't responding to therapy, right? And you should take note of this within the first 24 to 48 hours and get the surgical team involved. And you don't want to delay it, especially if you've administered iodine, because then you'll really only have a week before the Wolff-Chaikoff effect wears off. And once the decision for thyroidectomy has been made, patients have to be medically optimized. And plasmapheresis has been shown actually to rapidly convert patients to a euthyroid state within about 3 days. And this is just a study that looks at another preparation protocol to prepare patients for surgery. And it involved 17 patients, not too large of a number, and they had amiodarone-induced thyrotoxicosis, they had Graves, and toxic multinodular goiter, admitted to Boston Medical Center. And the indication for thyroidectomy ranged from unsuccessful medical therapy to noncompliance to very large goiters. And all of these patients received 500 milligrams of iopanic acid, 1 milligram of dexamethasone BID, beta blockade, and if tolerated, thionamides. And all of their T3 levels came back to normal within 4 days of treatment. Now, the reason this isn't applicable to us here is because iopanic acid isn't used in the United States. So, there are no studies on the risks of hyperthyroidism on non-thyroid surgery, But in general, with these patients, there's a heightened cardiopulmonary response. They'll have an increased cardiac output, they'll be tachycardic, they might be in AFib, and their chronic hypovolemic state from their increased metabolic rate may lead to an exaggerated hypotensive response during induction to anesthesia. And perioperatively, you want to use volatile anesthetics because they blunt the sympathetic nervous system. And that's what I have.
I'm sorry, are there specific beta blockers that are used? Did you say that?
Just propranolol, I think, is a preferred agent.
And that's because it blocks the